Moving into my case, camouflaging Kawasaki disease, unusual presentation of Kawasaki disease. Our story begins with a previously healthy and immunized 9 months old male baby boy presented with low-grade fever, rhinorrhea, and cough. Chest X-ray was done and showed picture of bronchopneumonia with no improvement on home treatment for 1 week. 1 week after, our patient started to develop respiratory distress, abdominal pain, and high-grade fever. On examination, he appeared toxic, febrile, tachycardic with bronchial breathing and diminished air entry more on the right side. These were his initial labs on presentation. His hemoglobin was 10, a microscopic hyperchromic anemia, platelets 761, a high TLC count, CRP 168, ESR 52/100, with normal kidney and liver function panel. This is chest X-ray on presentation. It showed a heterogeneous opacity on the right side with an obliterated costophrenic angle. Right chest tube was inserted for drainage, which showed a small amount of pleural fluid, which was exudative. But was sterile, and so as blood culture. COVID PCR was negative as well. Antibiotic course was started in the form of ceftriaxone and amikacin. Patient started to be febrile after 48 hours of antibiotics with improvement of his general condition and decline of CRP to 90. Chest tube was removed on day 5 after no drainage. But on day 7, he started to develop fever again with appearance of extremity swelling and unilateral cervical lymphadenopathy. On day 7, on reappearance of fever, his hemoglobin was 7.9, platelets became 933, TLC 15, CRP became 266, and serum albumin was 2.9 milligram per deciliter. Pan culture were withdrawn and results were negative. No improvement of fever after, even with broad-spectrum antibiotics. We shifted from amikacin and ceftriaxone to vancomycin and meropenem for additional 5 days with no improvement of fever or any of the inflammatory markers. That was his CT chest. It showed a picture of right upper lobe around pneumonia with mild fibrotic changes on top, with right middle lung lobe post-inflammatory or fibrotic changes. So we requested echo. His echocardiogram showed a left main coronary artery with a dimension of around 3.7 millimeter on Z-score plus 3.9. His lead was 287 with Z-score of plus 3.2, and CX showed a Z-score of around 1.96 with normal RCA. We also noted mild mitral regurg, mild pericardial effusion around 5 millimeter anterior to RV was noted as well, with good biventricular function. Diagnosis of atypical Kawasaki was made, so IVIG on 2 gram per kg was given over 2 days, plus aspirin on anti-inflammatory dose, 50 milligram per kg for 2 days after fever has subsided, and then we shifted to an antiplatelet dose. Actually, we hesitated to give aspirin for the fear of Frey syndrome, but that was the decision. Fever has subsided dramatically after 36 hours of IVIG, and high-dose aspirin was continued for another 2 days and then shifted to antiplatelet dose. The patient completed 3 weeks of antibiotics with clinical, laboratory, and radiological improvement. Labs on day 19, platelets became 710, CRP 1.1, and serum albumin of 3.5. That was his serial chest X-ray. On day 19, it showed marked improvement. Echo on day 21, left main coronary artery stood normal dimensions, and so as lead. So to summarize our case, we had a 7-month-old male boy with right side exudative pleural effusion and pneumonia, diagnosed after 12 days of admission as a case of atypical Kawasaki for having a persistence of fever with no improvement on broad-spectrum antibiotics, swelling of extremities with cervical lymphadenopathy, a high inflammatory marker, supportive echo findings of dilated coronaries, mild mitral regurg, and mild pericardial effusion. So he received IVIG and aspirin with dramatic improvement. So atypical Kawasaki is a term used to describe patients with incomplete presentation of the disease and usually constitutes up to 36 of all cases of the disease, with cervical lymphadenopathy and extremity changes are the commonest features. It has been linked to pulmonary changes including bronchopneumonia, pneumothorax, or pleural effusion or empyema. So the question to ask, is it the infection that triggers Kawasaki disease in genetically susceptible patients, or vasculitis as a part of the Kawasaki disease induces non-infectious pulmonary vascular permeability changes? So our key points to learn: always suspect Kawasaki disease in cases with the term a difficult to treat pneumonia with no response to antibiotics with prolonged inflammatory reaction. The presence of relatively uncommon clinical features should not be a deterrent in considering underlying Kawasaki disease in such patients. Consider IVIG even after the window of 10 days in the presence of persistent fever and ongoing inflammatory reaction. And finally, it is essential to continue antibiotics course after IVIG, as many cases reported in literature, Kawasaki disease is a post-infectious manifestation. Thank you all.
Dr. Naguib.
Yes, it's okay.
Commentary.
It is a really interesting case, very difficult to make the diagnosis in such a situation. When we go through the literature, we find that there is a lot of situations where Kawasaki is associated to infections. So, which is important that we never have to rule out the diagnosis of Kawasaki disease in the presence of infection, because it's a common situation. But this case is very difficult because it was pneumonia, and we don't used to see pneumonia in Kawasaki disease. It's described, but it's not the way to reveal the diagnosis. It is the difficulty of this case. And I can say bravo to the team who take care of this patient, because it was not easy to think about Kawasaki, even though there was some criteria of Kawasaki disease. You said adenopathy, but adenopathy is not a typical or specific sign. So it was not easy, and maybe in case of patient, febrile child with who not responded well to antibiotics, we have to perform echocardiography. It can help to make the diagnosis of Kawasaki disease.
Yeah, thank you. I do have a commentary. This is a very good presentation, Dr. Barsoum. Actually, we will be discussing tomorrow in full on the guidelines for Kawasaki disease in the Arab countries, and we include quite a few items, including the conclusion you mentioned in your presentation in the end. One of them is not to exclude your infection, as just mentioned, but the other one also is to reconsider when there is no definite diagnosis, even after 10 days. Even if fever goes down, then goes up again. So thank you so much.
Thank you for this rich discussion about this case. And Mariam, you have a commentary?
Just a question. I want to know if you look for the etiology of the pneumonia. Did you search for mycoplasma or adenovirus? Because we know that these two infections are trigger frequently Kawasaki, adenovirus infection and mycoplasma.
Actually, we did not search just for a limited resources. So we could not perform this panel.
Thank you. You have a comment, Dr. Ashraf?
Yes.
Yes, Dr. Ashraf.
Thank you so much for the great presentation. One of the things that I learned from Najib is the difference between incomplete and atypical KD. I know that 2017 American Heart Association statement used the words interchangeably. So I would like to invite Najib to explain what he explained to me, and I want him to teach us all the differences between incomplete KD and atypical KD. Thank you.
Thank you, Dr. Ashraf.
Yeah, exactly. So Kawasaki disease used to be known with the 5 criteria plus fever, and which means they have the complete criteria and complete presentation. In 2007, it was well published with the American Heart Association that patients who do not present all 4 or 5 features should be included as Kawasaki disease. So if the criteria are not complete, we call them incomplete Kawasaki disease. But they have the same risk, they have treatment the same, and especially the same risk of recrudescence of fever as well as coronary complications. In the past, we used to call it incomplete or atypical, but since 2007, we keep the term atypical for any Kawasaki disease, complete or incomplete criteria with any unusual features. For example, if you have arthritis, if you have severe pneumonia, if you have other features that are not typical of the Kawasaki disease, then it is called a atypical disease. It could be with or without complete criteria. So it's important to maintain this. And we are mentioning this in the Kawarabi guidelines. We are still working on this. One last word, if you don't mind. Besides pneumonia, there are only few cases where pulmonary hypertension with acute Kawasaki disease are published, a few case reports. So besides pneumonia, it is true that vasculitis in the lungs is a true thing. It's not it is unheard of because it's rare. So it is atypical to have pulmonary hypertension, and typically it will resolve spontaneously. I would invite you to search pulmonary hypertension and Kawasaki disease, and you'll find these case reports. So I guess we'll move now to the next case.